Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Good afternoon, everyone. First of all, thank you so much for taking some of your valuable time to attend our presentation for today. Inshallah, it's going to be worth it. So our talk for today is about sleep medicine, which is a medical subspecialty that's focused on diagnosing and treating sleep disorders and sleep-related concerns, which if left untreated can lead to a significant long-term consequences like hypertension, diabetes, heart diseases, and so on. Our main goal for today is to describe and discuss with you some of the main and common sleep disorders in the community and the right way to manage them. We're going to start with a simple game, and then we will take a few minutes to explain briefly to you how sleep disorders can affect different age groups, and we will end our presentation by an enlightening and educational talk by our special guest, Dr. Muhannad. So we're going to start with the game. As what you can see, we have here the spinning wheel. We have 6 different topics, and we have a question for each one of them. So basically, you're going to participate. We're going to spin it for you. Tell us whenever you want it to stop, and then you have to answer the question in a specific amount of time. If you get the right answer, you're going to get a gift. If no, then thank you for participating. Okay. So who wants to start? Okay, go ahead. Let us know whenever you want it to stop. So you're going to start with the clinical case. You're going to see the question, and then after you read the question, we're going to start the timer, okay?
So a 25, I didn't even read it. Okay, so a 25-year-old man comes to the hospital for general fatigue. He says that he doesn't feel rested in the morning and that he snores a lot. His wife says that she noticed that he seems to stop breathing on several occasions during the night. So what's the possible? Exactly. So you are absolutely correct. Sleep apnea mainly related to abnormal breathing during the night.
You're gonna get your gift at the end, okay? Who wants to go next? You.
A 19-year-old female comes to your clinic with 3 months history of on and off unusual sensation in her legs. She described it as a strange, uncomfortable sensation with an irresistible urge to move it. She mentioned that it starts in her left leg, then a few weeks later, the right leg starts to have the same sensation. She also mentioned that the sensation increases at night, which makes it difficult to fall asleep or stay asleep. She denies having the same sensation in other parts, so what's the possible diagnosis? You guys are very well, mashallah. So yes, the restless leg syndrome is the right answer. Okay. So for low melatonin, the main presentation will be difficulty falling asleep. There could be some neuropathies, but other symptoms need to be present. For sleep apnea, we already discussed it, where abnormal breathing should be present.
Okay, who wants to go next? Yes. So again, you're gonna read the question, and then we're gonna start the timer after we are done with the question, okay? So an individual is
displaying rapid eye movement, suppressed muscle tone, and is difficult to wake up. When he awakes, he reports dreaming. The cycle of sleep he was experiencing is? Correct answer. So the clue word in the question is rapid eye movement, which is the same name of the stage. And also, this is the stage where we are experiencing dream.
Okay, who wants to go next? Yes. So we're gonna consider that dreams because like the clinical case already taken. You're fine with that? Okay. For this one, the timer gonna start directly. Okay? How much percentage? Good job. How much percentage? The question is how much percentage of our dreams do we forget? And that's the right answer. Actually, we forget most of our dreams. And there are like some hypotheses about that. One of them is that actually the norepinephrine, which is one of the essential chemical that we need to memorize and remember things, will be at its lowest level when we are dreaming. That's why we will not be able to recall and remember things when we wake up. Okay, who want to go next? Yes, you. Again. Okay. Now the same thing. The timer gonna start directly with the question, okay? Which of the following graphs correctly represent the amount of time an individual spent sleeping? See? Okay. That's right, actually. Good job. Now, if you think about it, like the normal person should sleep for 8 hours on average, so it's 1/3 of the day. If you take a look at this graph, which represents a life of someone who lived for 79 years, from these 79 years, we spend 26 years sleeping in the bed. And we spend another 7 years in the bed trying to sleep. So it's a total of 33 years in the bed. If you compare that to other things, for example, work, it's only 30 years. Unless you are a medical student, then like it's different. Eating, it's 4 years and a half. So the sleep is the main thing that we do in our life because it's very important, as what the doctor is gonna discuss with you. Okay, who wants to go next? Yes. I think باقي واحد. Only one. Yeah, I think we only have one question remaining, right? So the unknown one, okay? The timer is gonna start with the question. Which hormone is referred to as sleep hormone? Actually.
Do you know where melatonin is secreted? Your answer. Do you know where melatonin is secreted? Yeah, okay, you're correct. It's secreted in the pineal gland, and it's called sleep hormone because it regulates the sleep cycle. Thank you.
So, mashallah, all of you did it right. So, please remember to take your guests before we are done. Okay?
Now we'll leave you with our colleagues Rahaf and Tawhida, and they will talk with you about how different sleep disorders will affect different age groups.
Okay, so I'm going to start off with narcolepsy. What's narcolepsy? It's a chronic sleep disorder characterized by overwhelming daytime drowsiness along with sudden attacks of sleep. It can happen in any age group starting from childhood to 50 years of age, but the two peak time periods are as follows, one being around the age of 15 and the other being at the age of 36. It is believed to be underdiagnosed in kids for some reason. Next we have parasomnia. Parasomnia is when you have unusual physical events taking place which disrupt your sleep, such as sleepwalking and sleep talking. It's most commonly seen in children aged 5 and the ones that are above. That's why it's more common in children and they're more prone to it. And it's thought to be because of their brain not being mature yet. Next, we have sleep apnea. What's sleep apnea? It's when you have abnormal breathing patterns. And what you do is that during your sleep, you stop breathing for a while, and then you get back to your normal breathing pattern. All of that happens while you're still asleep. It affects people of all ages, including the pediatric group, and it particularly affects people over the age of 50 years and those that are overweight. Okay. Next, we have RLS. What does RLS stand for? It stands for restless leg syndrome. It's when you have this strong urge to move your legs, and it's usually due to a very uncomfortable sensation. It affects most commonly within the age range of 50 to 59 years. The lowest prevalence is seen within the age range of 18 to 29 and those aged 80 and above. Insomnia is something that we all have been exposed to at some stage of life, at least majority of them. And it is when you have disturbance of sleep and when you have trouble falling asleep. It is more commonly seen in those over the age of 60, and this could be due to a variety of factors. Medical and psychological factors that lead to symptoms of insomnia are most commonly seen in seniors.
Now, lack of sleep, regardless of the cause, regardless of the age, it will impact our life somehow. So they will have affecting in the memory and the concentration, and it will lead to lack of our performance. And if we talk about children specifically, it will lead to decrease or it will have problem with our learning difficulties. It will lead to learning difficulties compared to other children. And if we talk about adolescents, they will have increased risk-taking behavior such as alcohol or drugs. And for adults, it may increase sensitivity to the stress, so they will have difficulty managing the stress because of the lack of sleep. And in elderly, at the end, they will have, in addition to confusion, memory, it may lead to depression and decreased mental function.
Our guest speaker for today, Dr. Muhannad Hawari, consultant pulmonary and sleep medicine, director sleep medicine unit in King Faisal Specialist Hospital and Research Center, and he is a professor at Alfaisal University. He is going to talk about sleep mechanism, sleep disorders, and how to diagnose sleep disorders. And he also going to talk about sleep apnea, treatment and management. So,
Assalamu alaikum and good afternoon, everyone. It's a very pleasure to be with you today, and I'd like to thank the organizers for inviting me. You have no idea how exciting this is for sleep physicians to see such a talk being presented in the university for undergraduate students. I remember during our undergraduate times, we never heard of sleep medicine or sleep disorders. So personally, I only knew about it during my residency. So seeing students talking about this is really, really amazing. So talking about sleep medicine for 40 minutes is nearly impossible, but I'll try to come across the most important parts. So we're going to talk about sleep physiology and the neurobiology of sleep. We're going to talk about how we investigate patients with sleep disorders with what we call sleep studies and polysomnographies, how to approach a patient suspected to have a sleep disorder. We're going to come across obstructive sleep apnea because it's one of the most important sleep disorders that we see in the sleep clinic. And then just briefly to give you some idea about other sleep disorders. So I hope you find this interesting. This is what we see on the other side. So this is the part that we see. This is only maybe 2 minutes of data. So when the patient is sleeping for 6 hours, you can just imagine how much data we are collecting and how much time it takes to score and analyze this study by our sleep technologists. So what we see here in the first three channels, the EEG, and then we have the electroocculogram, we have the ECG, we have the nasal and thermal sensors, the abdomen and chest belts, and so on, and the oximetry here. So we keep on looking at this in windows every 30 seconds or 2 minutes, and we analyze each and every one of them. So you can just imagine how much one sleep study takes to analyze and then eventually to report. So what is the classification of sleep disorders? So we have what we call insomnia disorders. We have sleep-related breathing disorders, hypersomnias, parasomnias, circadian rhythm disorders, and sleep-related movement disorders. Now let's start with obstructive sleep apnea because it's one of the most common sleep disorders that we see in the sleep clinic. Now, just to go into some definitions, an apnea is a complete or a near complete cessation of airflow. We call it obstructive when there's an ongoing effort to continue breathing, meaning that the chest and the abdomen are still moving. So the patient is still trying to breathe despite the cessation of breathing. We call it central when there's no effort to breathe, meaning that there was a signal from the brain to stop breathing completely. An obstructive hypopnea is a significant reduction in airflow with ongoing respiratory effort, and it's associated with either arousal from sleep to fix it or a desaturation by 3 to 4%. Now, when we do a sleep study, we like to score these apneas and hypopneas throughout the night. And then we end up with something called the apnea-hypopnea index, the AHI. So we lump up all the obstructive apneas and hypopneas we had, we divide them on a total sleep time, and then we come up with an index of how many times per hour would the patient stop breathing. So the apnea-hypopnea index in normal people should be less than 5. If in a sleep study you score more than 5 per hour, this by definition is called obstructive sleep apnea. So obstructive sleep apnea is what we see on the sleep study. We say that this is mild obstructive sleep apnea if the AHI is between 5 to 15 per hour. We call it moderate if it's 15 to 30 per hour, and we say this is severe obstructive sleep apnea if it's more than 30 per hour. Obstructive sleep apnea syndrome is what we see in the clinic. So obstructive sleep apnea syndrome is a patient who had a sleep study showing obstructive sleep apnea with the clinical, physiological, and psychological findings of obstructive sleep apnea. Now, we still believe that obstructive sleep apnea is a bit underdiagnosed in the community. So, for example, the states, they say that it's about 5%. In Saudi population, according to studies that came out from the Sleep Disorders Center at King Khalid University Hospital, about 38 to 39% of the Saudi population are at risk of obstructive sleep apnea, possibly because of the high incidence of obesity in our population. And it seems that men are more affected than females. So when we say obstructive sleep apnea, about 24% of men are at risk of sleep apnea compared to 9%. And we say obstructive sleep apnea syndrome is about 42%. So it seems that there's more of a male predominance in such disease. Now, when we talk about obstructive sleep apnea, we're talking about a problem with the airway, the upper airway. Now, as you see, the upper airway starts from your nostril and your mouth and go all the way down to the epiglottis. You think of the upper airway as a collapsible cylinder, a cylinder that can collapse. There are some forces that try to keep it open and some forces that are trying to collapse it. So what tries to keep it open is the function of the upper airway muscles. Okay? So as these muscles are functioning very strongly, the airway will be open and maintained. Also, the longitudinal traction. So as the lungs are expanding, it is pulling down on the upper airway, making it strong and stiff and preventing it from collapsing. So these are some findings or some forces that try to keep the airway open and preventing it from closing. On the other hand, what tries to close the airway is the negative pressure we generate when we take a deep breath in. So that negative pressure is trying to pull the airway inside. Also, the extra luminal pressure and the amount of tissue around the airway, and this is why obese patients are at risk of obstructive sleep apnea, that amount of tissue is causing significant compression on the airway. So these are forces that will try to keep the airway or try to collapse the airway. And it is the result between these two forces that will determine whether the airway will remain open or will it collapse. So how do patients present with obstructive sleep apnea? What are the common symptoms? Snoring by far is the most important finding and symptom patients present with. And when we say snoring, it's not something that happens occasionally, like when you're tired or when you have a flu or have bad rhinitis. No, we call this habitual snoring. So this is a habit that the patient always has. And the snoring usually is very loud and very disruptive to other people. So the bed partner usually is the person who drags the patient to the clinic, saying that the patient snores very loudly to the point where the bed partner or roommates cannot sleep anymore. So the snoring is usually loud and very disruptive. There's something called witnessed apneas, and this is a part of the history we take from the bed partner on the roommate. So the bed partner would tell you that the patient snores so loudly, but there comes a moment where the patient just stops breathing completely for a couple of seconds, and then the patient suddenly takes a deep breath in and starts breathing again. So we call this a witnessed apnea, meaning that somebody actually saw the patient stopping breathing when they're sleeping. Sometimes the apneic events could be so bad to the point where the patient actually wakes up from sleep and starts choking or gasping. Okay? And this is a very specific finding in patients with obstructive sleep apnea syndrome. Because they stop breathing a lot, there's lots of drops and oscillations in oxygen and CO2. And for that reason, their sleep is always interrupted. The brain has to wake up every now and then trying to fix the problem. So they don't sleep very well. The sleep is always interrupted and they wake up a lot at nighttime. This is a very common statement we hear from patients. They always say, no matter how much I sleep, I always wake up feeling unrefreshed as if I never sleep. Even when they go to sleep in the weekend, they always wake up feeling tired and feeling unwell. So unrefreshing sleep. Waking up with morning headaches because of the oscillations in CO2 and oxygen levels. And then because of the poor quality of nighttime sleep, this reflects into excessive daytime sleeping. So what are the risk factors for obstructive sleep apnea? First of all, as we said, it's a problem with the airway. So anything that will make the airway narrow will make it more liable to collapse. So for example, patients who have retrognathia or macroglossia, or children who have large tonsils or adenoids, anything that will make the airway narrow will make it more liable to collapse. Obesity is by far the most common risk factor. About 70% of obstructive sleep apnea patients are obese. So obesity with a BMI more than 30 to 35 is considered a major risk factor for obstructive sleep apnea syndrome. Males are more affected by sleep apnea in comparison to females because there's more androgen that affects the function of the upper airway muscles. On the same line, ladies who are postmenopausal are 4 times more likely to have sleep apnea in comparison to premenopausal ladies. So postmenopause is an important risk factor for sleep apnea. Some habits like alcohol intake and smoking, because it affects the function of the upper airway muscles. The age, so if your age is more than 60, you are more liable to have sleep apnea because the airway muscles start to become floppy and more easy to collapse. And then if there's some family history of sleep apnea syndrome. If you want to do a very quick assessment in your clinic, if you're not a sleep physician, if you're an internist or a family physician, this is a questionnaire that you can go through very easily to tell you whether your patient is at risk of obstructive sleep apnea or not. And we call this the Stop Bank Questionnaire. So it stands for S, which is snoring, T for history of tiredness throughout the day, O for observed apneas by the bed partner, history of hypertension, B, BMI of more than 35, age more than 50, neck circumference of more than 40 in males and 43 in females, and being a male. So we score each one of those with 1 point. And if you end up with 0 to 2, this is low risk for sleep apnea. Between 3 to 4, this is moderate risk. And if more than that, then your patient is at high risk of obstructive sleep apnea and should be referred to a sleep clinic for further evaluation. So in a sleep study, this is just a glimpse of what we see in patients with obstructive sleep apnea. Now, as you see, this is a very busy and hectic picture, but I'm going to ask you to focus in this part here. This is how the patient is breathing. This is a normal breath here, up and down. And then suddenly we see that the patient stops breathing completely. During this time, the patient is still trying to breathe, so the chest and the abdomen are still moving. And with that, the patient has an arousal from sleep. So the EEG shows awake arousal from sleep for the brain trying to fix this event that happened. And with that, the oxygen started to drop. So as the brain woke up, the patient started to take a normal breath again. But when the patient goes to sleep again, the same thing happens, and so on and so forth. Okay? So this is an example of a patient with obstructive sleep apnea. So the question comes, should we really treat obstructive sleep apnea? So far, I gave you at least 2 reasons to. Number 1, snoring could be very disruptive to other people. So the bed partner could really come to you complaining that snoring could not make him or her sleep properly. So snoring could be also embarrassing to patients. So management of snoring. 2 is management of poor quality of sleep. These patients are always unrefreshed, tired, and sleepy in their daytime and have poor quality of sleep and quality of life. So you want to fix that as well. But let's take it one step further. Studies have shown that obstructive sleep apnea increases the risk of coronary artery disease, and heart associations look at sleep apnea as a risk factor for coronary artery disease, same way they look at hypertension, diabetes, and smoking. So you do increase the risk of coronary artery disease. Patients can have hypertension, specifically uncontrolled hypertension, or hypertension in the young. they're more prone to have strokes, more prone to have uncontrolled diabetes, more prone to have gastric reflux disease. They can end up with pulmonary hypertension. It can worsen their heart failure. It can cause cognitive changes and abnormalities like changes in memory and concentration and irritability. It increases the risk of accidents because of excessive daytime sleepiness. And we had patients in the sleep clinic who presented mainly because of sleeping while driving and having a car accident, injuring themselves or other people. And this is a very important medical legal aspect of sleep medicine. It has a poor quality of life, poor performance at work. It does affect mood by causing depression, and it can have some social problems between bed partners and husband and wives and so on, and an overall higher mortality in comparison to normal people. So now that I've showed you this slide, do you really think that we should treat obstructive sleep apnea? The answer is absolutely yes. So how do we treat obstructive sleep apnea? There are different treatment options. Positive airway pressure treatment, whether CPAP or BiPAP, is considered the gold standard of treatment. I'm going to talk about that in the next slide. There are other options like oral appliances, surgeries, and some behavioral recommendations we give to patients. So continuous positive airway pressure or CPAP treatment is considered the gold standard in managing of patients with obstructive sleep apnea syndrome. The way it works, it delivers a fixed pressure, a continuous fixed pressure. That positive pressure splints the airway open. So when the patient is sleeping and the airway is about to collapse, this fixed pressure splints the airway open and keeps it open and patent, preventing it from closing. It is very highly effective and considered the gold standard in managing patients with sleep apnea. We always need to know what pressure is really needed. So we need to do something called titration to know what pressure the patient really needs to treat their obstructive sleep apnea. So this is just an example of how it works. So the patient will wear a mask connected to a tube, and the tube is connected to the device. The pressure will go through the tube to the mask, and that will come all the way down to the upper airway, and that will splint it and keep it open when the patient is sleeping. Other treatment modalities include what we call oral appliances. So these are custom-made devices that go inside the mouth, usually done by dentists, and it pulls on the lower jaw to keep it open and patent when the patient is sleeping, and we use it for mild to moderate patients with obstructive sleep apnea. Surgical interventions, whether it is at the level of the uvula or the base of the tongue or the maxillofacial surgeries, could be effective in some patients. And some patients have a positional predominant obstructive sleep apnea. So they have sleep apnea when they're in the supine position, but in the lateral position, they do very well. So we can give them some devices that force them to sleep on the side and prevent them from going on their back. So this could be helpful for some patients as well. Some behavior recommendations, we always recommend weight loss. Weight loss is very important for patients who are obese. It will improve the severity of sleep apnea. In patients with mild to moderate sleep apnea, it might go away completely. So this is something we strongly recommend, and sometimes we do liaise with bariatric surgery clinics for our patients. Patients who are alcoholics should stop alcohol because it worsens the sleep apnea. Avoiding benzodiazepines because also it can affect the upper airway muscles. Smoking for the same reason, and avoiding sleep deprivation. Other common sleep disorder breathing that we see include the obesity hypoventilation syndrome and something called central apneas. I'm not going to go through that a lot, but these are other examples of sleep breathing disorders. And sleep breathing disorders is the part of sleep medicine that brings pulmonologists into the field. So let's talk about some of the non-respiratory sleep disorders that we see in the sleep medicine clinic. Insomnia is probably the most common sleep disorder we see in the clinic, and it happens in about 10% of the population. But we don't say that include, and I thank you for inviting me. Thank you. So do you have any questions or? Okay. So, how many patients? Okay, so I'm going to tell you something that I'm not very proud of. In the sleep clinic, the waiting time is 1 year. So if you refer a patient to me now, I'll see him next year. Yeah, so actually, and our coordinators are here, they can tell you that they can. Because there is a lot of demand on the sleep clinic, and unfortunately, some resources are still needed. So we need larger sleep labs, we need more sleep clinics, more sleep physicians. Still, sleep medicine is under-recognized in the healthcare system. We need like a sleep study or a sleep bed for every 5 patients or 6 patients. Now we have 1 bed for every like 100 or 120 patients. So we're still way behind in managing patients, for example. Sleep paralysis can be either primary or secondary. Some of the most common secondary causes include alcohol intake, sleep deprivation, medications. And then there are some patients who end up with what we call isolated sleep paralysis. It does have some family history in about 6 to 10% of people. Sometimes it could be very mild that patients just experience once or twice in their lifetime, but sometimes it can be so frequent and it causes mainly strong psychological impact on patients, and then that's when we treat it. Any other questions? Welcome. Welcome. Thank you. It depends on the situation. Sometimes we try to do it ourselves in the sleep clinic whenever we have the time, and it has to be more than one session with your patient because some patients don't follow what you're saying right away. And we always tell them that you have to follow what we're telling you by the word. It's not just the spirit of what we're telling you. It's exactly doing what we do. So sometimes we do it in our clinic in sessions. Sometimes we refer to psychiatrists, and there are some psychiatrists who are specialized in it actually. So they like to accept such patients. If the patient is comfortable with it and starts understanding it very well, they can continue doing it. I think there are some videos online that they can go and do it themselves as well. Welcome. Any other questions? Okay, with that I conclude. Thank you so much for having me.